Good evening. Thank you for joining us for tonight's educational webinar on ACL updates. Tonight's speaker is Dr. Rodney Comisar, OrthoNeuro Orthopedic Surgeon. Dr. Comisar is a board-certified and fellowship-trained orthopedic surgeon who specializes in sports medicine-related injuries, offering a full spectrum of sports medicine surgery, including arthroscopy and minimally invasive procedures. We are having some technical difficulties tonight, so we ask that if you have questions during the presentation, please put those in the Q&A, and we will review those at the end of the presentation.
Good evening. My name is Rod Comisar. I'm an orthopedic surgeon at OrthoNeuro. I specialize in sports medicine. As Amanda said, I primarily problems of the knee and shoulder. I do shoulder replacements as well. So we're going to talk tonight a little bit about an update on ACL injuries, treatment, and epidemiology. And please stop us as we go with questions. I'm sorry, we'd like to take them as we go, but I can't see them for some reason, the way the Zoom setup is here. So a brief overview: what's the ACL? The term, the anterior cruciate ligament. It's cruciate stands for cross. It's a ligament in the center of the knee, along with the PCL behind it, responsible for controlling rotation, as well as translation, or critical for cutting, pivoting, change of direction, sports, and activities. Some numbers about epidemiology: estimated 250,000 injuries per year in the US. It's probably higher. It seems like each year as we get more people being active in sports at all ages. The prevalence in males is higher. That's both new injuries and older existing injuries, whereas females have a higher overall incidence or a newer injury. In fact, the injury rates in females have been shown to be 2 to 6 times higher than men. And we can talk more about that and why as we go forward. It's generally athletes aged 15 to 45, but certainly it can be your laborers and sometimes just lay people doing activities of daily living that have the misfortune of getting hurt. Typically up to 80% or more can be what are felt to be non-contact injuries, meaning it's not like a blow to the knee, although that certainly can happen in a sport like football. We tend to see more contact injuries in males because of their contact collision sport participation, but the majority of these injuries are non-contact injuries. In general, estimate 74 per 100,000 people a year undergo reconstruction. So again, this probably is older data, but 175,000 or more ACL reconstructions a year, and I think that trend continues to rise. It's termed to have satisfactory outcomes, 75 to 97% in one meta-analysis. We always just say 80-85% of patients do well. How do you define well? We'll talk more about that as we go forward. Primary ACLs are estimated to occur in 0.6% of adolescents and 0.8% of all high school basketball players. So not high, but higher than you'd like. And certainly the younger patients, specifically the females, seem to be most at risk for a variety of reasons. So again, we talked about mechanism of injury, primarily non-contact. I landed from a jump. I planted my foot to change directions. My knee popped, it shifted in. Sometimes even slowing down or decelerating can cause it, although typically it is associated with changing directions. Certainly skiing too, like the torsional aspect of skiing can also produce a non-contact injury. And then your contact injuries like the bottom right with Tom Brady kind of getting hit from the side with a planted foot. We see that a lot in hockey and wrestling, etc. So what are some of the risk factors? There's a variety of reasons that are associated with these injuries. It's certainly multifactorial. There are some hormonal factors. It's been shown that there are estrogen receptors on ACLs, and so there may be a contribution there as to why females perhaps are more vulnerable, and it may vary depending on the cycle of the month, so to speak. Similarly, there's been some new work at a genetic level where there may even be a specific gene that might predispose patients to this. Obviously, not much we can do with that information other than maybe use some preventative efforts, which we'll talk about more as we go forward. There's also neuromuscular factors. When we say that, we're talking about like the sequence of how your muscles fire. It seems to vary in men and women and between athletes and non-athletes with respect to the sequence of how your quadriceps and your hamstring muscles fire with certain activities. Similarly, just weakness in the hamstring, sometimes in the hip abductors, which can control stance and give you a stable base, also can be influences on these type of injuries. There's anatomic factors. Certainly women have a smaller bone, so a narrower notch, so to speak. You can see in the distal femur that's flexed in that picture on the left. It's kind of an arch or a U, inverted U in the middle, and that's where the ACL resides. So the smaller that notch is, the thought is that may predispose to tears just by the fact that the ACL may hit the side or the top of the notch, so to speak, and lead to a tear, and such as a hyperextension episode. Men, wider knees, maybe a little less of a factor. So the other thought is that women if they have a wider hip or wider pelvis, then kind of have more narrowing towards the knee, like we call valgus orientation, like they're on the far right. And that also puts some abnormal stresses across the knee and specifically the ACL. Lastly, there are environmental factors like shoe wear and more specifically turf. Certainly become a hot topic in the NFL with respect to types of injuries to soft tissues of the knee and Achilles specifically. So how do these patients present? Often I land from a cut, I jumped, my knee popped and gave out. They often will describe a shifting sensation as something like came out of place in many cases. The majority of the time, the patient might report a difficulty weight bearing, leading them to not be able to continue in their sport or activity. There's certainly some cases where people said I walked it off and kind of went back out, but that's certainly not the norm in these cases. Generally, is a fairly rapid amount of swelling that happens within 6 to 12 hours, or certainly within a day. Not always, but again, that's also can be a tip that something like this has occurred. And in some cases, patients will walk it off, go back to whatever they're doing day to day, and then find out, hey, my knee buckled again a couple times within several hours after my injury. Or if they wait several weeks to get seen, sometimes they might feel better enough to go back to their sport and then have a recurrent injury or recurrent giving way episode, so to speak. So how do we make the diagnosis? Well, often with experience, you can almost make the determination from the history. You can just hear what they'll tell you happened, and you'll think, oh, certainly it's associated with certain individuals, certain activities, but you can sometimes make that diagnosis before you even lay hands on the patient. So watching them walk in with a limp, they're swollen. The top left is called a Lockman test, with the patient laying flat, getting relaxed, and then he's been about 20 degrees. So basically, you're trying to pull the lower leg or tibia forward as that arrow direction. That's kind of considered the gold standard test. The other test below that's called an anterior drawer, and it's also helpful, but it's not quite as foolproof in assessing these patients. Sometimes it can be difficult because the patient often is in pain or guarding. It's hard for them to relax, and so it's not always as straightforward as just doing a Lockman test. Imaging, we start with x-rays. The majority of the time, those are going to be normal. We're looking really for associated injuries with fractures, perhaps arthritis, which may change your treatment. It's certainly depending on the age of the patient. An MRI, the bottom right there, shows a normal ACL from the side on the left, and then a torn ACL on the right. Also, the MRI can be helpful in ruling out other injuries to the meniscus cartilage, the articular cartilage, which is like the shiny coating on the end of the bone, and also the other ligaments, because sometimes you can get involvement with other structures like that that would change your treatment perhaps. Just a brief review of knee anatomy. The picture on the right shows a torn right ACL, so the ligament's kind of coming up from the bottom right, and it's kind of blunted off. It should be kind of diving back and connecting to the femur and that arch, kind of the top left area, if you will, but it's kind of popped off, and that's what we call the stump of it. You can kind of see some of that blood. It's kind of like a blush, reflective of the injury. Behind it is the PCL, and you can kind of see this as an example of a right knee. So you have the menisci, which are like little washers on either side, like C-shaped. They're kind of blue structures we see. Then the femur is the thigh bone, and that white articular cartilage. We're seeing the front of the patella. So there's similarly a white cartilage on the back of the patella, and then on the lower leg. Similarly, the tendons that are not reflected here, but there's a quadriceps tendon which comes off your thigh and connects to the top of the kneecap or patella, and then the patellar tendon goes from the kneecap or patella down to an insertion on the tibia or lower leg to help kind of with knee extension. So those are all potentially at risk with these injuries, some more than others. That's also why we try to avoid recurrent injuries, because maybe the first time you have something happen, you just tear your ACL, but if you kind of neglect it or go back to sport and have re-injury, then that's why sometimes those other structures can be injured subsequent to that. Once the ACL is torn, it's gone. It's not going to heal, and you can't really re-tear it. It's already kind of out of commission. So initial treatment is pretty simple. Like many things, you know, the acronym RICE, so rest, ice, compression, elevation, trying to get the swelling down. And that's really true for any kind of knee injury. First goal is to decrease the swelling. Sometimes if it's significant enough where the patient really has a lot of discomfort, can't bend their knee, maybe has difficulty lifting their leg, even controlling their quad, we'll drain the knee, or we'll call it aspirate. Typically it's full of blood in those cases, and that can often give relief, although it depends on the extent of that as to whether that's warranted or not. Certainly if patients are hobbling or limping, we provide crutches just because we think it's better not to limp around. It tends to kind of perpetuate the limp and also lead to more swelling and pain in the front of the knee. So if we can kind of slow them down on crutches, rest the knee, so to speak, and help them recover however they choose to treat the injury, whether it's surgical or not. Braces can also be used if some people feel like, wow, my knee is so unstable, I don't trust it, I can't even walk, much less cut or climb. And can you back up one, sorry. Bracing can be helpful. And then prehab kind of goes back to getting that swelling down, also getting the kind of the muscles of the quad firing, bending the knee, and working on a normal gait. And then you decide which treatment path we're on, so surgical and non-surgical. Next slide, please. So what are some of the indications? Obviously, our athletes, especially our younger athletes, but really athletes of all ages, fall into this category at this time. Some patients just want their surgery. They don't care if they need it or not. They want surgery because they don't like the fact that their knee is torn or their ACL is torn specifically. Certainly any desire to return to cutting, pivoting activities, or even whether it's sports or sometimes a job involves a lot of movement like that. And that's can be important to perform the duties of their position. Patients that have associated injury to the meniscus, especially certain types of the meniscus, involves a large tear. They call it a bucket handle. Will actually flip and kind of like get stuck in the front of the knee to prevent the knee fully extending. Certain types of injuries to the articular cartilage or the joint lining and other ligaments can necessitate earlier treatment. Or perhaps if someone's on the fence about it, we may say, well, with this, if you add this to the picture, it kind of tips us towards a surgical treatment option sometimes sooner than later. Relative contraindications are if you have moderate to severe arthritis, where really we think your biggest problem is going to be pain from the arthritis, that you may be closer to a knee replacement than anything else as your next procedure. That can be a contraindication. Similarly, some patients are low demand. They're like, hey, this is a freak accident. I don't really do much. I'm a couch potato. I don't think I want to go through surgery. Those patients can be treated with a rehab program. And then, you know, if they're bad, but some patients actually, if they try to choose that course, find out, hey, I don't think I'm that active, but I find that I cannot function like this. They may even flip into a surgical pool later on. Other relative contraindications are age, and we use that term loosely. Certainly when I was in training, I think anyone over 40, we'd consider them, hey, those patients are too old. We don't do that. Well, obviously not the case anymore. I have patients in their 50s and sometimes even 60s. So really try to categorize like how active they are physiologically. Some patients in their 60s are more active than people in their 20s or 30s, and we don't want to penalize them for that. Similarly, someone who's not really willing to participate in rehab is not probably a good candidate for surgery, or if they have comorbidities or other factors that just doesn't allow them to rehab properly and use crutches and braces and things like that when it's indicated. Next slide, please. So ACL surgery, the timing is variable. We used to say, hey, you got to wait 2 to 4 weeks from injury. You want to get your swelling down, get all your range of motion back. It seemed like that was important for recovery in the sense of less risk of stiffness. There have been some studies more recently that refute that suggest, hey, you can go ahead and operate on someone right away. I think in reality, every patient's knee is a little different. They don't all look the same. Some knees come in big, swollen, they're stiff. They need time to kind of calm down. Some patients walk in and it's very subtle and they almost don't realize anything significant happened because they may have a little bit of swelling. They got their range of motion back fairly quick, and it can kind of almost fool them a little bit in the sense that they may not have much pain. Their movement's back. They walk good. It can kind of give them a little bit of a false sense of security in some cases. So we try to encourage an early evaluation so we can at least give them a sense of what's safe to do and what's not. Generally, the surgery is done arthroscopically and involves rebuilding or reconstructing the ACL. Once the ACL tears, it doesn't heal. Repairs are something that are done in a very small subset of patients, and it's somewhat controversial, which we'll maybe mention later. But generally, reconstruction involves using a tissue from allografts are available, or a donor or cadaver who donates a similar tissue. Often patients over 40, although that's not a hard rule. Certain patients that are revisions, meaning the second time they've had their ACL done, where you don't want to go back and take more from the other knee, or the same knee rather. And sometimes what they call multi-ligamentous injuries, meaning you've not only torn your ACL, but you tore your PCL. And then I had a guy the other day that had his LCL too. So we're dealing with 3 ligaments, really aren't able to take all that from one knee or the opposite knee to rebuild it without causing a significant amount of morbidity and add to difficulties in their recovery. Certainly, we want to address associated pathologies. The picture on the bottom left reflects a meniscus repair. You might see those sutures in there. That's a lateral meniscus of a left knee. So the cartilage, the white cartilage up is the femur, below is the tibia, and that C-shaped structure is the meniscus. Similarly, then on the far right below is a mealy, so you can kind of see there's an irregularity to the surface of the cartilage. The cartilage is like the coating, so it's so thick. That's kind of a partial damaged area to the medial femoral condyle, so you kind of can smooth that down. Sometimes if it's deeper, you can do some additional treatment where we actually drill up into the bone, try to get some bleeding out, almost like trying to put a scab on it, if you will. And then we talked about those other ligament injuries. Some of them can be repaired, involving your collateral ligaments, like your medial lateral collateral ligament. Reconstructions are typically involving PCL or posterior cruciate ligament, as well as sometimes, more often than not now, lateral collateral ligament injuries too. The last thing that's relatively new or in vogue with treating ACL injuries is the idea of what they call an augment. And it's almost like the idea of what we refer to as a belt and suspenders. So you fix the ACL, there's some other things we can do to kind of back it up or reinforce it in higher risk populations, which we're going to talk about here in a minute. Next slide, please. So what are the grafts? Autografts, typically you can use your patellar tendon. That's kind of been the gold standard. That's one in the bottom middle, where you take a sliver of bone in the middle of your tendon and a sliver of bone. Hamstring tendons on the left, there's 3 on the inside. We take 2 of those 3, or in some cases just 1, depending on how you're trying to make your graft, so to speak. And lastly, the quad tendon is a newer one that's come into vogue more recently and has become very popular for a variety of reasons, where you can take a slip of the middle part of your quadriceps tendon. Some people will take a little block of bone off the patella. Many of us won't. Allografts are donors, and you can basically get all those autografts you can get from cadavers as well. In addition, there's some other grafts that can be used that you wouldn't take from a patient, but you can take it from a cadaver and use, including your Achilles and a variety of tendons around the ankle. That's there because they're long and they're relatively large in diameter. So you want a good sized graft to kind of reconstitute or recreate the normal anatomy and collagen of the ACL. Allografts are great. There's a cost to them. They can be fast. You don't have to take those from the patient, so there's less pain. The biggest negative is the failure rates have been shown to be roughly 4 times that of using autografts in younger patients, specifically in the 10 to 19 age group in certain studies, but also really anyone under 25. Very high risk to use an allograft primarily for their main or for their index surgery, if you will, even up to the age of 40. So more and more, depending on patient's activity level, they don't have any other problems with their knee in the past, no pain, no early cartilage wear on the patellofemoral joint. We tend to err more on the side of autografts. I think if patients are uncertain, I say if you feel more comfortable, use your own tissue if there's any doubt. Some patients don't like the idea of having a cadaveric graft in their knee either. So they'll make those decisions for a variety of reasons, and we can kind of help push them to make the best one we think as far as safety and longevity. Next slide, please. The anterolateral ligament, that's that augment we talked about. It's first described by anatomist Stephen Clace. It's also felt to contribute to rotatory instability of the knee. It's often injured concomitantly with the ACL. In the top left picture, it's the I have a pointer. It's the one kind of coming forward towards the front. I wish I could indicate that better to you. There's a guy from Lyon, France, Bertrand Sonnery-Cote, who kind of did an extensive series with the ALL reconstruction, many soccer players, and basically showed, and combined with his ACL reconstructions in these young active patients, up to a 60 to 70% reduction in re-rupture rate, which is tremendous. I mean, we're always trying to have the perfect surgery and say everything works all the time, but we just can't do that. So we're constantly trying to improve on our results for our patients. Now, there's another similar procedure called a lateral extra-articular tenodesis, kind of a mouthful, or an LET, where basically you take your IT band, which runs from your hip all the way down below the knee. You can take a little strip of that, and that's reflected by that bottom right picture where you see that void in that kind of moving from bottom right to top left. That's your IT band. So you can take a slip of that and route it underneath your lateral collateral ligament, kind of a sling effect, and it helps take some of the stress off your graft, and it seems to be protective. But Pat Smith, who's an orthopedist at the University of Missouri, does a lot of ACL surgery, has published a lot, and basically showed that functionally these two seem to be equivalent. It was kind of dealer's choice as to what you use. Okay, next slide, please. What are the indications? So these patients, certainly the revisions, meaning they've already torn their ACL once they had surgery, they tear it again. Revisions are when we're using this procedure. High-grade pivot shift, which is kind of like a rotational test we do under anesthesia, where the knee really kind of jumps. So it's not just coming forward, but there's kind of a rotational kick to it. Patients who really hyperextend a lot are thought to perhaps maybe be more at risk of amputating that graft as their knee came into extension or hyperextension, especially those narrow notch people. Younger patients, certainly we're looking more and more, should we be doing these primarily on every patient? Maybe that's a little overkill, but trying to be more selective with young patients who are active in sports, who are doing pivoting sports. Maybe we can protect them and save them from a second surgery. So the bottom left shows the ALL. And some people are doing it like with 2 bands, where it's almost like a upside down V or a forked graft. And then on the bottom right shows that LET, or lateral extra-articular tenodesis, which I've come to use much more frequently than I had 3 or 4 years ago. The Get Good is a Canadian guy, spearheaded the stability multi-center trial where they basically added the LETs to hamstring ACL grafts in a high-risk group of patients and showed a reduction in graft failure, as well as persistent or less rotational laxity measured compared to the normal knee at 2 years after surgery. So promising results, and that's what's gotten people interested in these procedures. Next slide, please. So post-op care, it can vary in my hands. Patients are on crutches for 4 weeks, brace for that time plus another 2, so 6 weeks. The first week we kind of lock the brace, which is pictured in the bottom left, in extension, so it helps you get straight, and then everything else you're doing is helping you bend, whether it's therapy on that device on the top right, it's called a CPM, or continuous passive motion machine. You put your leg in it and it slowly starts bending your knee. I've used them, and my trainers used them in residency and fellowship. So you kind of tend to be a product of your training. It seems to work well. I've used it pretty much my whole career. Some people will use them for total knee cases as well. We use braces. Now, some doctors don't use crutches. I feel like that's maybe okay in some patients. I think most patients need some kind of support. I don't think they're ready to walk out of the OR. But there's some evidence definitely that early weight bearing helps the recovery. So you put them on crutches doesn't mean no weight. The only time we might do that is after some big meniscus repairs and other things that we don't want to injure, perhaps like articular cartilage work we've done. But in general, we start to let them weight bear and then kind of go up like in an incremental fashion over the course of several weeks. Physical therapy is important. I start it fast within 2 or 3 days after surgery. Give the patients kind of their marching orders so they have a home exercise program. The more they do on the home program and use the CPM, it can often pay dividends. But the therapist can be helpful. It's hard to just do it on your own, I think, especially what's pushing the bending. And also like later on, it's hard to know what's safe to do and what's not. When can I ride a bike? When can I jog? When can I add these weight training exercises, etc.? But some people don't use braces after surgery. Many people don't use CPMs. There's a lot of ways to quote skin a cat and wind up with the same results, certainly. Next slide, please. So return to activity in general terms, these are some just basic guidelines. I allow patients to run at 3 months or 12 weeks unless they've had a meniscus repair or had some kind of articular cartilage surgery. Sometimes if they've had additional ligament surgery, depending on how much, that also could push that back. Return to labor work conservatively, I'd say 3 to 4 months to start, depending kind of what they're going to do. They have to do everything. Maybe that's not realistic. If they can go back in a limited capacity, often in some form of brace, either the post-op brace or perhaps that functional brace that's demonstrated in the bottom right. That's more of a sport brace. You might see that in soccer or football. Returning to sport in general, that's kind of evolved over time. It used to be how fast can you get your patients back, and realize that didn't work very good sometimes. So I tell my patients, longer and longer time frames, it seems now, maybe 6 to 9 months. Certainly the older the patient, I think maybe even a little longer than that, just because I think they're busy with life and work and maybe don't devote themselves to the rehab to the same extent maybe the athletes can or in high school or just aiming for their next, sports season, if you will. And then functional bracing can be helpful for sports as well as for the workplace. They also can be used for patients that opt for no surgery, that maybe just want to have a brace for certain activities. Guys that live in ski towns, I think, that recommend their patients to wear a brace forever. I don't know if that's realistic, especially when you have some that have 2 ACLs, and I don't think they're going to wear 2 braces, but just something to be aware of. Next slide, please. So bracing, it doesn't seem to affect the re-rupture risk. I used to brace all my patients. I've kind of come around to, we recognize that it's maybe not for everybody. It may affect their proprioception or their ability to kind of feel themselves in space, so to speak, and may not be good for muscle development. I think ultimately the protector is going to be your muscle of your leg, really your core down, and especially your quads. And some of the data we'll talk about in a minute reflects that. So I've kind of softened my approach for braces, although some people I think kind of want them at least early on when they first go back, or basketball, soccer, but certainly for your collision sports like football, hockey, it's hard to brace wrestlers and rugby players. So we maybe go to a softer brace and just tell them, hey, we really need to make sure your strength is sufficient to be protected for you. It may lower the severity of an MCL injury, which is why you see a lot of like college linemen wearing them. Someone rolls up into them. It may not keep them from tearing their ACL, but they may not have a severe MCL injury. The Mars cohort, which is a multi-center ACL revision study, which looked at redos, basically showed the ACL brace was helpful for return to sport, at least in what was called the COOS score. So it's basically what we call patient-reported outcome measures. So it's not like Rod Comisar deciding if that was a good outcome. It's the patient saying, hey, that was helpful for me to go back to sport compared to, maybe not using one. Next slide, please. So the role of performance testing, what does that mean? Well, performance testing is what we call return to sport testing. So there's a study at one of the American Orthopedic Society for Sports Medicine in 2017, which I thought was really telling. They basically looked at all their athletes before they return to sport, or whatever the time frame. 38% of the patients who went back to some PTs and go through some strength testing, balance testing, and hop testing retore their ACL. Only 5% of the patients in their series who conversely went through their return to sport testing and passed all those measures tore their ACL again. So it's not foolproof, but it certainly lowers that number. And then 4 patients who went back to sport within 5 months, so kind of fast from those timelines we were talking about, how they've evolved. All those patients re-injured their ACL within 2 months, which is unfortunate. So that picture in the bottom middle is called a Y balance test. So you kind of do each leg, and you stand on the left. He's trying to reach to his back left, back right, and then forward. And then similarly, you do it with both your injured leg and then your non-injured leg. Next slide, please. Another return to sports study, Grindam, in the British Journal of Sports Medicine 2016, basically looked at patients post-ACL reconstruction who went back to level 1 sports. So cutting, pivoting, change of direction, your basketball, soccer, volleyball kind of stuff. Compared to the ones who went to other types of activities or sports, have nearly 4 times the re-injury rate in the first 2 years back, which is kind of disheartening. They did notice that as quad strength improved in those patients, it significantly lowered the re-injury risk. And basically their recommendation, which is somewhat intuitive, is that the return to sport testing really shouldn't just be time-based, meaning like, hey, I had my surgery 7 or 8 months ago and I'm ready to go. It's also based on functional criteria. Some of those functional tests we talked about, looking at the quad strength and hamstring strength and duration or intensity on both the operative leg and the non-operative side, but also single leg hop, and then a Y balance test. We showed you that Y balance test on the last slide. The hop tests are basically, you do a single hop, a triple hop, hop crossover, like one side the line to the other, and then a hop for distance and time. And so they compare it to your good leg. And so all those things can help tease out like deficiencies in the strength that may, predispose someone to re-injury. Next slide. Re-injury rates. So roughly half the re-injuries happen between 6 and 12 months post-op, which is devastating. They've already missed 1 season, they got back, and then they got hurt again. It seems as if reaching 9 months post-operatively seems to be somewhat protective. I mean, there's a little bit of a drop-off. If you can wait that long to go back to sport, it seems like less people are getting hurt again. Darren Johnson out of Kentucky at the arthroscopy meeting in 2017 showed the re-injury rate really drops off precipitously if you can make it out 2 years past your surgery. So that sounds great, but no one's going to wait 2 years to go back to sport. Nevertheless, if you can kind of weather that storm and get to that point and kind of be cautious, then it seems like you're in pretty good shape. How can a Journal of Bone and Joint Surgery in 2019 also just talked about an increased risk of ACL graft injuries and contralateral or opposite knee, which stinks, really stinks to have the second leg torn. I saw one yesterday who just got released from one side and then tore the other. And it's your young active patients, particularly females, soccer players and also basketball. Female soccer players have a 30% re-injury rate, meaning they either re-tear the same ACL or they tear the opposite knee, which is kind of mind-blowing. When you think about that, that's 3 out of 10 people. It's really something we're trying to figure out how we can be better. Next slide. So outcomes, we talked about that. Everybody does good 80 to 90% of the time. And that's often when the surgeons are making the calls, that feels good, your knee looks good, it doesn't swell, and you have good movement. But the patients were like, hey, something's not right, it's not there. So as we took more patient-specific outcome measures, asked them how they felt about their knee, the results weren't quite as good. Especially going back to sport, it was clear that patients might return to sport 70 to 80% of the time. But if we ask them, are you back to your old level? And the results weren't quite as good. You might see, 60 to 61%. There's one series at 2 years that less than 40% were back to the same level of sport. So certainly it probably depends on, it's multifactorial in the sense that it depends on what sport you're talking about, what their rehab program is like. But nevertheless, it's not a slam dunk to get back to the same level of activity. It does seem that younger patients do better. elite athletes in some cases actually may do a little bit better too, just and that maybe because they have that special it that makes them unique and elite. The Norwegian knee ligament registry really does a good job of capturing all their patients. 86 and 94% of those CUS, or those patient reported outcome scores, are normal within 2 years. But that involved a lot of intense rehab and even prehab, which is harder to do. We used to send a lot of patients to therapy before surgery, but now we're much more hesitant to do that just because of the cost. And patients often have a limit on how many visits they can get in a year. And so you want to kind of bank those for the post-op period. So we tend to kind of instruct them on their own beforehand. So maybe that's not ideal. The prehab has definitely been shown to be helpful. Certainly patient motivation, education, and kind of constant reiteration of your goals. And lastly, a lot of repeated functional testing, which is nice, but that can take some time. At least functional tests may take an hour or two, and you don't always have the time or the resources to devote to doing that. But it seems to help, and certainly reflective in the good results they had in that series. Next slide, please. So ACL risk factors. This is the JBJS is what's turned the Journal of Bone and Joint Surgery. So they came up with like a clinical summary. And so basically in looking at some of these risk factors we talked about before, some are what they term non-modifiable. So that would be like gender, right? You can't change the fact that you're a female. Anatomy, you can't really change your anatomy, your notch, the slope of your knee, ligament size, everything. That's kind of, it is what it is. The modifiable risk factors were things like environment, so AstroTurf. So that's why you're hearing more of a push in the NFL to go away from that and get back to natural grass, but also neuromuscular factors. And that's really the big thing that we're trying to learn from. And also program and soccer players internationally has really shown promise as far as reducing re-injuries. And so what can do is maybe teach people how to land. A lot of girls that get hurt land stiff-legged, so we try to teach them to land, especially like in volleyball or basketball, with a little bend to their knee, kind of recruit their hamstrings, which leads to the knee bend that's a little more protective. Similarly, when you cut, maybe round off your cut and make it not as much of a hard jump stop or immediate change of direction. That seems to be protective. Some of those are obviously learned behaviors. And this girl, the picture on the right, you can kind of see how she went from where she has a kind of that narrowing wide at the hip, narrow at the knees. So it's kind of a knock-kneed picture, if you will, on the right, or on the left rather, and on the right, as her strength improves, it kind of straightens her leg. And that's felt to be much more protected by strengthening her hip abductors, which kind of help you in stance, the kind of the outside muscles of your hip. Next slide, please. So look at all these ACL prevention programs again through this JBS clinical summary. They reviewed 5 of these programs, and 2 of them demonstrated improvement in injury risk and athletic performance. One is called Sport Metrics, which was based out of Cincinnati. There's a famous kind of ACL surgeon named Frank Noyes, who's still like, I think in his 80s. He may still be working, but he kind of founded this, and that's shown to really have some positive impact. Also, the Prevent Injury and Enhance Performance Program, or PEP. They did a meta-analysis of 8 of these programs across a bunch of studies or series, and showed that there was a 52% reduction in risk in females and 82% or 85% rather in males. Another series took female basketball players over an 8-week trial and really showed how they were able to improve the ratio of their quadriceps to hamstring strength. So kind of showed that the hamstrings were more balanced, if you will. Also improved their loading mechanics and reduced the torque in their knees, which in theory should lessen the risk of injury. Another series demonstrated that female soccer players led to 3.3 times lower risk of non-contact ACL injuries, and that's kind of how the majority of them happen for them, unfortunately. It's also shown to be cost effective, whereas a universal ACL prevention program reduces the annual incidence of these injuries per season from 3% to 1.1%, with a cost savings of $100 per person or player per season. That's hard to quantify, but at least it shows a little bit of the impact it can have. The hard thing about those programs is if there's a cost to it, who's going to bear the cost and the time? So I think those of you that have soccer or basketball players are playing club, they're busy. Coaches don't want to devote a lot of time to these programs. So it's we need to show them meaningful data that it makes a difference. Otherwise, we, share this with athletes individually, and they kind of have to do it on their own time. So orthobiologics refers to like a catch-all phrase for really ways to enhance healing with blood products. There's a variety of things that have been used. You might have heard the term PRP, which stands for platelet-rich plasma, basically where you spin out various products and separate those that are felt to promote healing from a positive standpoint. And PRP is one of them that's been used injected in knees. We've injected in our knees after ACL surgery for years. Other promising areas are some surgeon and Dr. Lavender, I believe his name, what the term of fertilized ACL. So when you do surgery, sometimes you'll get some bone kind of chips, or not even, it's more like mulched up, pulverized bone that you can kind of save and put back in what we call the tunnels. So we drill the tunnels to make a new ACL and try to put some of that bone back in there to help the healing, especially tendon to bone with certain types of grafts, because sometimes, it works well, but it's not, maybe not as well as we'd like. With that, you can use various demineralized bone matrix products to help fusions and heal fractures that have trouble healing. And then lastly, bone marrow concentrate. When you hear the term stem cells, it often means bone marrow aspirate. So you can go into a hip or into someone's tibia, pull out some blood. That bone marrow will contain stem cells that could be concentrated and also delivered back into the knee, or specifically into these tunnels to help with the healing. Early on, there's certainly some promising results, but more studies are needed trying to define the cost, because there is a cost to it. And then you have to decide, well, who will bear that cost? Many insurers won't pay for it. So then is the patient willing to share that cost? We have to kind of show them the data that it is meaningful and worthwhile to justify that. Next slide, please. ACL repair historically was fraught with failure, did poorly. There's been some resurgence in the last 10, 15 years about ACL repairs. The slides on the top right show, I wish they were larger. I probably should have edited that a little better, but proximal tears, meaning right off the femur at the top of the notch or close to that area, as opposed to in the middle or on the tibial side, those are felt to be the most amenable to this. There's been some case series where people either use suture anchors like we do in other parts of the body, like shoulder surgery and rotator cuff repairs, but also buttons, where these like suspensory buttons can be used. There's a series now that's called the BEAR procedure, which stands for Bridge Enhanced ACL Repair, where they actually use a collagen product derived from cattle or bovines, which is that bottom right, that kind of tube, and it's bathed in blood, or some of those orthobiologics we were just talking about, and basically placed kind of right in front of a repaired ACL. And it's shown some promise with respect to some early series a year or two out. And you don't have to have the morbidity of taking someone's graft or drilling tunnels. The holes for these repairs are much smaller. There's something called an internal brace. It's reflected by the bottom left picture, where you see that blue material going over the top of the ACL. Certainly the concerns of these, or this is somewhat newer and kind of out there in some people's minds. And so it's hard to subject your patient to something that if you don't feel confident it's going to work. We know the other way works. It doesn't work all the time, but it has a fairly good track record. And that's kind of the leap you have to make, to where, who's the right patient to try this repair on? Are they willing to give it a go with you? And then what the rehab's like. There's some differences early on as far as range of motion. They show some promise with respect to less pain from, that you don't have the graft site pain. And patients are pretty happy. So we'll see if this takes off. The goal is to obviously minimize the risk of injury, whether it's through this or reconstruction. That's what we want for our patients. It's devastating. So if it proves to do that, I think you'll see more and more of that in the future, but time will tell. Next slide, please. So what I'm hearing and seeing, I've been practicing since 2000. We do a lot of things different. I do a lot of things very different than now that I did back then. I think in general, we're seeing more of the quadriceps tendon autografts and probably less of the hamstring grafts. All the autografts do well, but the hamstrings have a little bit higher failure rate, it seems, in certain patient groups and also in certain individuals that are just small, and especially in certain women and young girls. And so that's a factor. We want a big graft, big tissue. We think that equates to more strength and less re-injury. More of those LET procedures or those augments, belt and suspenders. I think we'll see them more and more and trying to figure out who they're appropriate for, not for everybody. But if they keep our patients from getting hurt, I think you'll see more of them. Because it doesn't take a lot of time. It doesn't really change your rehab, and the cost is not that much more. Orthobiologics, as we talked about, more of those blood products, what's appropriate, what's not, what is just being wasted and what actually makes an impact. And that's where we're kind of working through with more of these prospective studies. Tibial slope, not something we talked about. But specifically we talk about anatomy, like the bottom right, you can kind of see this, what's called the slope of your tibia. So this is a side view of a knee, and you can kind of see how it's not flat or parallel to the ground. It's actually got a slope down. And so the thought is that the bigger that slope is, it may predispose patients to injury in some cases. And also then if you're one of those unfortunate patients that re-tears their ACL once or twice, sometimes they look at actually, do you have to change that slope and almost do an osteotomy where you cut the bone and realign that angle of the knee. And so that's something that's probably come back into vogue really come into vogue the last couple of years and being looked at critically. Not many people do it. I'm trying to learn it myself because I want to be able to offer it to patients if they have a need for it. We talked about longer times to return to sport. Like I said, it used to be fashionable, like how fast you can get your ACL back to play. And sometimes that wasn't necessarily for the best. And so I think the newer data suggest that longer is better. It's hard to sell that sometimes. People don't understand because they feel pretty good about 6 months or 5 months. And we try to encourage them to take it slow because you don't want them back in your office again, for obvious reasons. You want them to succeed and do well and move on. There's also more interest in these ACL prevention programs. There is one out of the hospital for special surgery in New York, or HSS, called RIP reps, RIP reps. I encourage people, if they have an interest in this topic, look it up online. It's got some cool programs, and they can give you some short little exercises to work on and attempt to be protective. Certainly the critically look at more patient-reported outcome measures, so more about how the patients feel about their knee, they trust it, can they do what they want, those kind of things that we want to be able to respond to. And lastly, a little bit about discouraged sports specialization. We know that playing one sport at an early age doesn't seem to be a positive thing and results in more overuse injuries. Certainly people that are playing those basketball tournaments or volleyball tournaments where they're playing 6 to 10 games on a weekend, or sometimes even a day, that's when you get fatigued. That's when you see these types of injuries. And certainly the more times you play, it's just more repetitions or volume. It's a numbers game, and eventually, unfortunately, many people's number eventually comes up. But we also know that playing different sports it develops different skills in our athletes, and certainly many of the people that make it to the professional level, especially in the NFL, it's kind of the case studies about the majority of them are 2 or 3 sport athletes. They're not playing football from second grade on, and that's all they do. So obviously football is different than basketball and soccer and baseball, but just as an example, we're going to try to promote kids developing multiple skills through various sport participation. And I think that's it. So hopefully that was helpful. Try to give you updates of what's kind of new in the last couple of years. I can't remember the last time I did one of these webinars, but please fire away if you have questions. I'm happy to answer them. Let's see if I can get to these. I don't know if does age have effect to repair? I think that I don't know if we know enough about repair to make that decision or determination. Certainly, it seems like we used to think that, well, adolescents and young adults often had more partial tears if people believed in that, to do repairs and older patients. I guess it's something we'll have to investigate if people are willing to take that risk, understanding that we're still trying to figure it out. I think that it could be done, but it also really depends on if your ACL is torn off the femur or what we call very proximally, as opposed to in the middle or on the tibia. But honestly, the majority of the ACLs we see are probably in the middle to top portion. So, many patients may be candidates, and we just have to decide as surgeons in conjunction with our patients, is this a good move for them or not? Because obviously we want it to work. Second question, is there a risk for additional surgery, say to remove scar tissue if proper rehab isn't done? Certainly that's a risk. Any surgery we do inherently by making an incision will create some degree of scar tissue. Some people make more scar than others. We don't know why that is necessarily. Certainly in knees, there's a tendency, especially if you don't get your knee straight after surgery, that sometimes creates some scar that will make it that much harder to get straight or get your knee fully bent. So we think rehab is the way to minimize that risk. It can't totally prevent it, but there is certainly a risk if the rehab maybe is suboptimal or not done properly. Any other questions, any other topics, or I don't know if there's stuff I didn't get into in detail. I'm happy to speak to. Another question is, do you think that field type has been playing a large factor to injuries? It's on the radar. Certainly there's concern about lower extremity injuries on turf to knees and ankles, specifically like Achilles. The thought is, hey, maybe field turf isn't as bad as the old historical AstroTurf, but now you've had some high profile athletes in football specifically having Achilles and other knee injuries, and now it's kind of put it back on the radar with the players union in an attempt to maybe move forward the idea that can we play on natural grass, that this indeed is going to be more protective. So it definitely has a factor. It probably depends on the sport and perhaps the level of participation, but it seems to have a role, and it's one we can control in a sense. It says, are ACL injuries more common with today's athletes than 20 or 30 years ago? I think they're probably a little more common for a couple of reasons. One, I did my training at 94 to 99, so that's kind of 30 years ago. So we saw ACLs. I think sometimes they were underdiagnosed, meaning, if you weren't sure what you're looking for, we didn't have MRI wasn't as available. I think sometimes people would see, no offense, like their primary care or an ER and just be diagnosed with a sprain and kind of be sent back out or by their trainer, not really recognizing the buzzwords and the things that kind of suggest an ACL. So I think we have a higher index of suspicion. And I think that also you have more people playing, right? Because when I was a kid, I played a little baseball and basketball and tennis, and then I got into high school. Well, now you have kids playing year round at a young level. Sometimes they're elementary school age, sometimes they're junior high. So there's a lot more repetitions, more exposures, if you will. So there's just more. And then you add female participation, which maybe wasn't as prevalent 30 years ago or 20 years ago. Those are factors. And lastly, you have people that are staying active well into their adult years and into retirement, that may be doing things that didn't happen before. So occasionally we'll see even more in that patient population. So yeah, absolutely, they're more common, and I don't think that's going to change, right? People aren't going to stop doing what they're doing and staying active. But I don't think we're going to have less numbers, for instance, as we go forward. Well, I hope this was helpful, and appreciate your taking the time to sign on and listen. Hopefully, maybe there's one more here. No, sorry. Let me bump this if I can get this. Maybe. Is there one? Question is, if I think I've had a tear, will I get an MRI right away? Generally, with knees and shoulders, if someone's had a traumatic injury, it's insurance will cover it. If we think it's warranted, if based on your history and your exam or combination, we think, yeah, this is kind of suspicious. And really the reason we want to be able to advise you is, regardless of your age and activity level, is, hey, you have this, so be careful if you do this, or maybe you really shouldn't do this at all. And it really kind of helps direct your activity and also counsel you on what the likelihood of a re-injury is, or if you hurt something else. And sometimes patients can have a single injury and do terrible damage to the meniscus and the articular cartilage, and just things that in a teenager that, will impact their knee well into their adult life, that's hard to fix. So we try to get ahead of those things. And if we feel like this has occurred, we want to quantify that and tell them what their risks are. And in many cases, try to treat it with a reconstruction to avoid that second injury that may do more damage if they've been fortunate enough to avoid it the first time. So yeah, the more often than not, I'd say get an MRI just so you know what you have, and then we can talk about options and depending on your level of activity and things like that. Questions, am I always right? I mean, it's never 100% accurate, but it's pretty good for a lot of things, not as good for others. It's certainly very helpful in this area. Especially it's good right after you get hurt. It's less helpful, like, if someone comes in 6 months or 2 years later. Certainly when it happens, you can see there's some bone bruising that happens. The knee kind of shifts and rotates, and you get the bones banged together, and there's just edema in the bone. And so that's pretty much pathognomonic, or kind of a sense that, yeah, that's what you got. But it's pretty helpful for this. And certainly if there's some that are like, hey, this is a partial tear, or we're not sure, the gold standard is for us, if we think it's warranted, is to put someone to sleep and really examine them under anesthesia. Because at that point, the knee's either going to move funny or it's not. And we'll compare it to the good side. And that's kind of the last check I use. So every patient I take for ACL surgery, once they're asleep, I examine their knee and confirm that, yeah, this is why I'm here. I need to be here and doing this before I proceed. So, and if I still am not sure, I'll put the scope in the knee and verify that before we take any graft from the patient's knee and start the procedure. So the MRI has certainly become very helpful in guiding this treatment. This also helps the patient plan a little bit ahead of time. So it's not always right, but it's pretty darn close. And there's some braces better than others. The question, there are, depends, what you're trying to accomplish. Certain braces are good just to kind of give some support for patients. Certain ones are good for like side to side activity, or like if you have arthritis symptoms. But the ACL braces that we showed earlier, there's several main companies that make these. They all fit a little different, but they are protective. They can help patients go back to skiing and certain like less maybe cutting sports, like maybe tennis, excuse me, which is more considered level 2, like doubles tennis, golf, hiking, that are sufficient. But for people that are trying to jump and cut and play basketball, it's if you don't have an ACL, the brace isn't going to be that protective. It's not going to save you, so to speak, for the most part. I mean, it's maybe there's one in 20 that can, but it's a numbers game. You do it enough, we think eventually your numbers are going to come up again, unfortunately. I don't know if that answers your question, but ACL braces can be helpful. There's another question. Have you heard about the new mending ends of the ACL with mesh? There's been some things used in the past, synthetic ligaments that didn't do well, where they really led to a lot of debris and almost like a blackish kind of appearance to the inside of the knee. That was years ago. The repair I was talking about, when you say mending ends, the Bear procedure, I haven't done one. I'm trying to learn about it and see if it fits into my patient population. It's shown some promise, at least the studies results that I saw, and it's done in conjunction with repairing the ACL. I'm not sure if that's what you're referencing with bovine collagen. There's another compound out there that uses it's not a graft like from a patient or a donor, but it's to kind of reinforce the ACL. I don't have any experience with that. It's not really widely accepted. I don't hear about it at the sports meetings, but I'm aware of it or familiar with it. The other device is this like internal brace I showed you that sometimes we use to back up our ACL reconstructions, or certainly the repairs. It's like they call it a fiber tape, but it's not it's basically really stout suture that maybe takes some of the stress off the ACL if someone was to have a misstep or a re-injury and try to protect that graft. Mending it with mesh, I'm not familiar with that, but I'm sure that there's a lot of things being looked at, like if you're going to get into ACL repair, what's the best way to do that? What's going to give us the best outcomes? There's a lot of things I imagine in trial, both in the US, but around the world. A lot of stuff happens around the world that never makes it here from a safety standpoint. But we're always looking to do a better job for the patients and maybe do it maybe safer or quicker or less pain, less cost, certainly. It's never ending kind of pursuit, I guess you'd say. Well, I'm going to thank you all for your time. If we can be of help with this problem or something similar, let me know. Similarly, please call the office. Be happy to see you. I got a Pickerington, New Albany, Westerville. I see knees and shoulders primarily, but I'll see elbows and ankles and other sports problems that occur during participation of our athletes. If you have other topics you'd like to hear about, please let us know. If you get a survey, we want to kind of give you the information you want to hear about. So again, thank you for taking the time to listen to me tonight, and have a good weekend.